Yeah, dear Easter, thank you very much for the kind invitation to speak here today. Yeah, I have some challenging patient cases which I want to present to you today. Two patients, and I think due to time, I will just start right ahead. I'm a dermatologist and allergist here at the UCARE in Berlin. And yeah, so I will start with a 27-year-old female patient. And she reported that she had cold urticaria since October 2022. And her symptoms were wheals of the skin, redness, swelling, and itching after cold contact, contact to cold liquids, cold air, and also cold objects resulted in those clinical symptoms. And this was very burdensome for her. Furthermore, she has a comorbidity, a lipedema in stage 2, and she also reported that she had cold-induced anaphylaxis in the past after a Baltic Sea bath. So Guido knows the sea well, so it can be very dangerous for patients with cold urticaria because cold can lead, generalized cold exposure can lead to a generalized mast cell activation with degranulation and systemic symptoms. Not only the skin is then affected, patients can also get difficulty breathing, can get a high heart rate, a low blood pressure, can feel dizzy. There can be a shock symptomatic, and it can be potentially a deadly disease. So a cold urticaria is really dangerous. So she experienced this cold-induced anaphylaxis, but luckily, she was treated and everything went well in her case. So this patient had severe impairment of quality of life, 22 points. This is a lot, means a severe restriction of quality of life. And as Leonie also already told you, the urticaria control test, UCT, 2 points, means very poorly controlled disease. You remember 12 points is what we want to reach, and in the best way, we want 16 points of the UCT, so our patient, no disease control at all. So we did laboratory testings, as also, Guido already showed you what we do, and in those testings we found only one thing which was remarkable, and this was her total IgE. The levels were very highly elevated. However, the patient had no further allergic or atopic diseases. And she tried several different antihistamines, as we have already discussed. And the last one was bilastine. She started with once per day. And we did also an updosing up to 4-fold per day, as the international guideline recommends. But there was also no effect in our patient. And she brought some pictures to me because, often it is that if you have the appointment in our clinic as a patient, then of course maybe it's warm or whatever. So it's always good to take some pictures of your skin symptoms. And the patient presented those wheals after cold contact, and you see it was a rainy day, so you can nicely see that there was rain, and she was in the car, and she had some wheals at her hands just while entering the car. It was very cold due to the rain, and she got those wheals. And here you can also see a picture of the wheals and the swelling and redness of the skin, which was also very itchy after a short bath. So she tried it again, but she left the sea because she got the reaction again despite the antihistamine. So what we do, and this is also something which Guido has already shown to you, we do a specific test, the temp test, to see how's the reaction, how's the temperature threshold in those patients with cold urticaria, but also with heat urticaria, and of course to confirm the diagnosis, but also to see in the follow-up whether our treatments work or whether we have to adjust. And you see this is of course exemplified. A patient, and in our patient, the temperature threshold was, despite treatment, 19 degrees. So you have to imagine everything below 19 degree results in wheal formation and itch, and this is quite high temperature. So again, a very burdensome disease. And this is a message which the patient wrote, and I wanted to explain to you that she presented with an important question. So she reported that she is having a major surgery, large area liposuction due to lipedema stage 2, which you can see here, her legs with the lipedema, but also with the reaction of cold urticaria. And she has therefore a question and informed her doctor and the anesthesiologist about the cold urticaria. And for many doctors, cold urticaria is not such a common or known disease, and they have many questions. And they would now like to know whether we need to take certain precautions before the surgery so that the urticaria does not occur during the general anesthesia. And probably her body will cool down during the surgery. And for example, she's asking, is there some kind of injection she could get in advance to prevent an anaphylactic shock, or is it enough to take the antihistamines? And so these are good questions. And unfortunately, we have no guideline which answer those questions. So we have to of course, look at her case individually, and we have to, we know that the risk of cold-induced anaphylaxis exists in patients with cold urticaria, especially in patients with a history of this cold-induced anaphylaxis. And the patient clearly had this history. So, of course, she has an uncontrolled disease, and this risk exists, especially if you have such a surgery where your body is longer exposed to cold, because the liposuction will be performed at bigger parts of arms and legs. So this is a topic which has to be thought about. Apart from antihistamines, we have no approved treatment options for cold urticaria, and this is quite a problem. However, we know omalizumab is nicely working in single cases of cold urticaria, but it is off-label. So it is an option, but of course we have to ask the insurance of the patient whether we can use omalizumab in her special case. And so it was a lucky situation, because we wrote an letter to the insurance, and we got the approval granted by the insurance for the patient. And another lucky coincidence was that already 1 week after the first administration of omalizumab, her TEM test results were negative, and the patient was symptom-free, which means urticaria control test 16 points, which was really great. So this was, of course, after 4 weeks assessed then, but it was a nice response to omalizumab. And I showed you the elevated total IgE, and this is a marker for those autoallergic patients. And that's why I decided, yes, we can ask for omalizumab, because if we have high levels, then we also have a higher likelihood that omalizumab works in those patients. And we just for precaution recommended a pre-medication with prednisolone for before the surgery, at the day, an hour before surgery, just to be on the safe side. And I was very, very happy when I got this mail from the patient that the surgery went really well with the treatment, and now she needs to recover and needs time to heal. So as a conclusion from the first case, I think it's clear that cold urticaria is a burdensome and potentially life-threatening disease, and it's very important to assess the disease activity and also the control for disease management, because if we don't assess those factors properly, then we don't know how to treat, how to improve, what to do. Omalizumab can be effective in patients with cold urticaria, but is not approved in cold urticaria. And for sure, we need effective and licensed treatments, because you need specialized centers where doctors have time to also write those paperwork and do all those extra steps. So it would be really nice to have also for cold urticaria, as for chronic spontaneous urticaria, further more treatments than antihistamines. So this is also a topic, and I think it is nicely underlining what Leonie said, the shared decision making is something which is very important, but also teamwork, because, you know, in those special cases where we also maybe need further information, further scores, further data, we really have to work together. And so I, from my experience, can only say that it's always very, very nice working together with patients for the same goal. So I think I have some minutes left.
Of course.
I will hurry up. So I have got another case, and this is has also recently been published. So you can also go into the literature and find this case here. This is a 58-year-old woman, and she had no history of allergies or rheumatic diseases. But you can see here in the picture, she had a 2-year history of spontaneous wheals. And interestingly, those wheals occurred daily. This is, they were accompanied by pruritus, burning sensation, typically appeared in the evening hours, persisted for several hours, and resolved without residual hyperpigmentation or bruising. This is a hint, thinking of urticaria vasculitis, but this was just not the case in the patient. So what was very interesting was that she also presented further clinical symptoms. Daily fatigue. She had bone pain, she had pain of her joints, her hands, feet, shoulders, and knees were painful. She reported myalgia, which means pain of the muscles, arms, and legs were affected. And she also had intermittent fevers and chills. And in the laboratory, we could find elevated inflammation markers. And a dermatologist diagnosed this patient with chronic spontaneous urticaria. And I think just from the skin, we all agree. So the patient was treated with several second-generation antihistamines, cetirizine, loratadine, fexofenadine. So as Leonie said, we tried different ones. So they tried different ones, and there was an updosing also done, up to 4-fold standard doses, according to the guidelines, but there was no improvement of symptoms. And we should think of the systemic symptoms which the patient presented, because this could be a hint for something else. And so we assessed the story, and then we thought, okay, so one thing which we could do is a skin biopsy. And Guido told you that we do it in cases of if we have a suspicion for urticaria vasculitis. But there are some other diseases which are also very interesting in the histology and can show clues. So we did this punch biopsy. You see this punch biopsy instrument. So it's a short thing to do. So it's like 4 millimeters of skin which we take out of the skin. So we do anesthesia before. It's really not painful at all, and it's very helpful for us, because if we can look into the histology and see this picture, and you see all those blue dots, so this is the upper part of the skin, and this is the deeper part of the skin, and you see many blue dots, and you have to believe me, those are neutrophils, and those neutrophils are not common in chronic spontaneous urticaria. I've brought you also a picture of the skin of patients with chronic spontaneous urticaria. You see only single of those blue cells, so single neutrophils. And Guido has already explained that it's a mast cell mediated disease. But now we have this wheals and this neutrophil-rich infiltrate, which is a hint for other diseases. And we did furthermore testing in the patient, and we found something which is called a monoclonal gammopathy. So we looked in her blood and we found abnormal proteins. And if we put all those things together, the urticaria rash with the neutrophils inside this monoclonal gammopathy, the elevated inflammation markers, and the systemic symptoms, then we can diagnose a very rare autoinflammatory disease, which is called Schnitzler syndrome. So this is a rare disease. 350 cases are reported in the approximately 350 cases are reported in the literature. However, it's a very important differential diagnosis of chronic spontaneous urticaria. And in this case, classic urticaria therapies do not work. Also, omalizumab does not work in Schnitzler syndrome. And interestingly, interleukin-1 is the main mediator of this disorder, and there are case reports and clinical studies which show that blocking interleukin-1 leads to reduction of the clinical symptoms and a normalization of the inflammation markers. They are very effective, but in this rare case, again, not approved. So I would like to conclude that it's very important that if we have this finding of urticaria plus systemic symptoms and non-response to antihistamine and omalizumab, we always have to consider differential diagnosis. Autoinflammatory diseases such as Schnitzler syndrome can present with chronic recurrent weirds and can be one differential diagnosis of chronic spontaneous urticaria. Often is diagnosis, of course, delayed because it's a rare disease. Many people don't know this disease, and a further awareness and research is necessary. And I am at the end of my talk, and I'm happy to answer questions.
Thank you so much. And even though we took a few more moments, I think it's very important for the patients to see also sometimes the resemblance of their disease and not to feel left out. So what would you say is the most important thing for the patient that is seeking the further care? Is it the documentation of the symptoms? Is it the qualified care, UCARE center? What should the patient look for if the patient sees their case in your presentation?
Yeah, so this is a very, very important topic. Please approach us. I think I can speak for all the UCARE centers. So we are here. So we have the website. We have a map of, the world. So look where's your nearest UCARE center and approach them. There are the contacts there, the head of the UCAREs. Write them an email, ask how to approach the clinic, how to approach the outpatient clinic, the specialized doctors. We take care. Of course, it's very helpful for us if you present with your documentation. Clinical pictures are always welcome. So take photographs and show them to us. But also, like if someone before did some histology or did some further testing, lab testing, for example, or maybe symptoms have already been documented in the Cruise app, for example. We have a nice app for patients with chronic urticaria. So this can already been done before the presentation. But reach out to your nearest UCARE and we'll find a solution.
Beautiful. Thank you so much. And now, since we have already went a little bit over our time limit, I want to just put a positive side into it. It means that there's still so much more to discuss in terms of urticaria, and we're eager to do that in the upcoming webinars. So once again, thank you, the panelists, for your great expertise, great presentations, and shared knowledge. Thank you for your time being here and dedicating it to our patients. For everyone that has been taking part in the webinar, I would gladly ask you on behalf of the whole team to share your experience with us and give us further input for the further improvement. Share the topics you would like us to cover. Please be sure to scan this QR code, give us the feedback, and please stay connected with us through the show's social media websites. Thank you, everyone, for making this webinar possible. I wish you a lovely day wherever you be. See you next time.